sometimes I send them back so they know that she's fussy. She's, I'm not actually, my therapist doesn't put my fixed retainers on for me. I do them myself. I'm that fussy about it. So I think it's just really making sure that your technician knows what you're expecting, and you're expecting a well-adapted passive fit.
Imagine you've hired some builders to create a building for you. Maybe let's say you're building a new dental practice, okay? So these builders come and they start building the foundation, and then they build the building upwards for your new dental practice. And while they're doing this, maybe they put some scaffolding everywhere to support the structures as they're sort of building everything up and making everything join up. Now, imagine the building is now complete, it's all done, but as the builders are leaving, you say to the builders, wait, what about all the scaffolding? You need to get rid of the scaffolding, right? It looks ugly, it's done, take off the scaffolding. And the builders say to you, no, if we take the scaffolding away, the entire building would collapse. You'd freak out. You'd be like, what the hell is this? What kind of building is this that's not stable? Well, someone once explained orthodontics to me in this way, using that analogy. And they said to me that orthodontics, like, what is that about? Like, they get everything straight, they get everything aligned, but unless you wear your retainers, everything will just collapse and go crooked again. And that's when they told me this building analogy. They said orthodontists are like these people who are leaving this scaffolding behind, because without the scaffolding, the building will collapse. Well, our understanding of retention has changed a lot over the years. I know back in the day, it's probably the reason why we see so many relapse cases, is that back in the day, we thought, or rather orthodontists thought, that if you put everything in a stable position and everything is class 1 and you get the correct interincisal angle, etc., that everything will remain stable and retention is not really needed long term. And we all know that this is completely false, and that retention, now the thinking is that retention is for lifetime. Welcome, Protrusive. I'm Jazz Galati to this episode all about retention with Dr. Angela Auluck. I mean, this is a mammoth. This is a huge topic in orthodontics and in general dentistry, because if they're going to an orthodontist, guess who they're coming back to? To their general dentist to maintain their fixed retainer or their retention. So I think as general dentists, even if you're not doing like orthodontics, we need to be well versed in retention, because this is something that affects so many of our patients. In this episode, we're going to talk about the very nitty-gritty details of placing a fixed retainer, about which is the most superior retainer, removable versus fixed, or do you always have to do both? So I know this is going to be a very impactful episode for those who are interested in learning more about retention protocols. The protrusive dental pearl I have for you is a communication one. Very often our patients will blame their lower incisor crowding on wisdom teeth. They will say, when my wisdom teeth came through, I started to get crowding. So is this true? Well, you should tell your patients, no, it's not true, because it was proven in a study by Harridan. Now, in the group of Harridan et al., what they did is they did a randomized controlled trial. They took people with extraction of wisdom teeth and they took people without extraction of wisdom teeth who had orthodontics, and they followed them up, and they found no statistical difference in terms of the relapse that they had. So this is something that we need to explain to our patients. Now, if you're wondering if I also know a study to help disprove the lady that says that her children sucked all the calcium out of our teeth, I don't have that study at hand, but you know what? When a lady just says that to me, I just ignore it, I nod, and we move on, because what are you going to gain from arguing, right? I mean, what can you possibly gain from arguing in that piece of the history? Just suck it up, buttercup, and move on is my advice. Anyway, let's crack on with this episode with Angela Auluck, all about retention protocols. Angela Auluck, welcome to the Protrusive Dental Podcast. How are you?
I'm very good, thank you, Jazz. I'm very excited to be on your show. I listen to you a lot. You didn't come up on my Spotify 2020, but you will in 2021. I discovered you quite late.
We talked with Goss about almost like GDPs versus orthodontists and when is it okay to compromise. And that was a very controversial episode. No one's heard it. And by the time this comes out, people will have heard it. But you know what? There's so much controversy. And the same thing I said to Goss is I'm going to say to you as well, that when as a GDP, I started doing my diploma in orthodontics, I thought that in restorative, there were different camps, different opinions. But the world of orthodontics is just polarized in a way. There's so many different camps and different ways to skin a rabbit. And I realized that more and more when I did orthodontist. Do you feel that when you got into orthodontics that was the case as well?
I think when you go through your orthodontic training, you actually leave there with very indoctrinated views about how you should be treating something. So I trained at the Eastman, so I do things the Eastman way, and you come out very confident, and you're right. As soon as you come out in the big wide world, it's almost a revelation, because you then realize that actually all the orthodontists around you are all doing lots of different things, and sometimes can lead to a little bit of sort of loss of confidence or questioning yourself. But, I think that's a great thing. We should always be questioning ourselves, questioning what other people are doing around us. But it should always be in a collaborative manner. It should be, okay, well, you do it like that. Why do you do it like that? Is that a better way? Should I be doing it like that? So, there's nothing wrong with everyone doing things differently. But I think as long as our results are good and of a certain standard, you're right. In orthodontics, there's many different ways.
Absolutely. And just like in restorative, I found that my mindset improved. And I like what you said there. And I'm going to say that my mindset improved and I became a happier dentist once I accepted that it's a beautiful thing in our profession, that there are so many different ways to do it. And if we see the beauty of that rather than see the frustration, then I think we can be much happier with ourselves. So definitely when I learned more about orthodontics, I was like, oh my goodness, I thought restorative had polarized opinions, different occlusion camp stuff. But now I learned about orthodontics. I was like, oh my goodness, this is so varied, but it's in a beautiful way. But just a little bit about yourself, Angela, and just setting the scene. Tell us a little bit about where you practice, how long you've been a specialist orthodontist for, a little bit about you, Angela.
So I carried out my undergrad training at King's. Whenever I do these kinds of things, I love mentioning sort of where I studied, because I find it gives me a connection to other alumni. So, hopefully after people have watched this, somebody might connect and say, oh, I went to King's too. And, there's another friend on Instagram. So, my undergrad training was at King's, and they were the best years, I think, of my life. I had such a great time there, made great friends, and my mentors, I would still say, are from there. And that's where I was inspired to learn how to move teeth. That's where I decided I wanted to be an orthodontist. After that, my postgrad training was at the Eastman. I'd always known that all I wanted to do was walk through that archway for 3 years of my life, and so I did everything I needed to possibly do to sort of get my place for orthodontic training there. And so I've been an orthodontist now for 15 years. And I own a practice with my husband in Wimbledon Village called the Dental Rooms. It's a specialist referral practice. So we have all the specialities under one roof. It's my second home. My team is my second family. All my time, effort, everything goes into that place. And it's the fruits of our labor, that place. And I thoroughly enjoy seeing my patients there. It's a perfect platform for me to be able to do what I really want to do, which is being part of a multidisciplinary team, helping the others achieve what they need to achieve with their work too.
It's so great to be able to work as a team, and you working alongside restorative dentists. What percentage of your patients are adults, and what percentage of these adults that you're treating are actually part of a bigger picture that actually after your orthodontic intervention, they're going to need a rehabilitation, implants, or significant restorative work? Can you just give us an idea of that?
Yeah. So my practice is a completely private practice, and kind of leads to seeing more adults than children. And I would say about 80% of my patients are adults. And of those, I would say probably about 30 to 40% of them are referred by one of the other specialists in the practice, or are referred by somebody external to the practice, but requires input from either the periodontist or the prosthodontist, endodontist, but a lot of prosthodontic and ortho cases come together, I find, in our practice. it's quite nice for the patients, Jazz. I was going to say that, they can sometimes end up with 2 or 3 specialists in the surgery with them. It just helps to make decisions faster, and, it wows the patients.
I had George Cardoso on the podcast who said a very similar thing to you. He's a prosthodontist, and he just opened my eyes to the fact that I actually myself need to work more with specialists as a multidisciplinary team, because you get to have more fun as a team. But there are a few little downsides to that as well, I guess. So I'm going to ask you, what's your pet peeve? What's the thing that annoys you the most about working with restorative dentists and prosthodontists? What's the annoying request that you get that actually this is completely unreasonable, or this is really annoying? Anything you could share in that light?
So it's always when me as an orthodontist with my orthodontist hat on thinks, okay, I've done it, I'm finished, I've got the teeth to exactly where he said he wanted them. And then they come in with their mirror or their shim stock. I hate shim stock. And they come in with their shim stock and they're like, but can you make this contact like a little bit lighter? And you're like, really? What are you talking about? It's going to settle. Leave it. It'll settle. And so, we sometimes have that kind of banter going on in the practice. But, you have to respect each other's philosophies and provide for them what they want. So yes, we don't have any arm twisting going on in the staff room saying, you have to say that case is finished when we see that patient together. I never do that.
I really like that example you gave, because essentially the prosthodontist ask you to intrude by 8 microns, but it's just hilarious, actually. Exactly. I quite like that one. So, let's dive into the massive topic of retention. So this episode is for everyone, orthodontists, GDPs, students, whoever you are, because retention is huge, affects everyone. So I want to start with a bit of contextualizing it, going back in time, because you probably get the same, and please tell me if you don't. The orthodontics that I do as a GDP, and yes, I have a special interest, got a diploma. A lot of the patients come to me, most of the patients come to me, and a lot of them have relapse. So they've had relapse, and I'm treating them as a second intervention of orthodontics. And they all have the same kind of story. Like, oh, you know what? It wasn't emphasized enough to me, or my orthodontist didn't really encourage me enough, or I didn't know, or my dog ate them and I didn't realize I needed to wear them. Do you think there has been a generational shift in terms of what orthodontists are saying 30 years ago to what they're saying now regarding the view on retention, or are our patients lying to us?
They can't be lying to us. So the studies are actually showing us that 70% of adult patients are coming to us because they have had orthodontic relapse. Not age-related changes, but orthodontic relapse. 70%, that's a lot. That's like a huge failure on the part of whoever is carrying out those treatments. Yes, I would say because, they're adults and they are mostly patients who have had their orthodontic treatment in their teen years. There has now, I think, been a change. So I think historically, even when I was doing my training, we were taught if you place the teeth in a certain position in terms of the occlusion, in terms of the soft tissues and the periodontal tissues, that it will remain stable. And it was almost sort of a hierarchical thing, you were only a really good orthodontist if you could if the teeth stay stable after you treated them without retainers. Like, what madness is that now when we think about it? So there was definitely a problem in the way that orthodontists were taught, but that those were real beliefs that we as orthodontists as a group that we had. But I think now there is a real big realization. The research now is so much better. We have randomized controlled trials to show us that teeth don't stay straight. So there's a lot of more research, and I think less head in the clouds. So yes, there has been a generational change, and I think actually probably a really big realization that teeth don't stay straight. They don't.
Awesome. I wasn't expecting what you'd say to that. Maybe I thought you would say that actually, no, we were doing it all along. But no, it's good of you to say that actually there has been a change in thinking, change in the evidence. And that's what we're seeing. And you're totally right. I mean, so many of these patients that I'm treating with orthodontics are relapse cases, adults, and it's always the same stories you have. So I'm going to jump on to the next question if you don't mind. So I'm going to say, if you had to have you had orthodontics, Angela?
No, well, I've had extraction orthodontics, so I have no canines,
Okay.
no lower premolars, but that was it. No, never a brace.
Do you wear retention? Do you have retention?
I don't have a retainer. I've never had orthodontic treatment.
Mm-hmm.
I don't have a retainer, but my teeth are moving, and I am on the verge of having some aligner treatment.
Okay, so let's hypothetically speak now, and let's say you've had that aligner treatment for yourself, for your own mouth. What would be your retention protocol and why?
Okay, so I would go for a lower fixed retainer because whenever I place a lower fixed retainer for my patients, the reaction is always like, oh, that's okay. It's comfortable. It's not invasive. And you know, there's always a very positive reaction. However, when I place the upper, no one ever is, you know, patients generally, you can tell if you read their sort of emotions or read them. The initial very first reaction is it's not comfortable, or it doesn't feel as good as the lower one. And, you know, that's obviously to do with the occlusion and also the anatomy of the upper incisors. So for the uppers, I would go for a removable retainer to be worn on a part-time basis. And I think that's also to do with the fact with the amount of risk in which teeth are more likely to move. So in my case, my lower incisors, I've got one that's beginning to rotate. That's going to be more unstable. I better hold that one. Also, age-related changes. I'm still quite young, Jazz. You know, I'm going to grow older and my teeth are going to move. So, yeah, in terms of age-related changes, we know it's the lower incisors that are going to lose their alignment. So why not hold those? So I would go for lower fixed and upper removable.
Brilliant. And I think I totally agree with my patient's perception after an upper fixed retainer. And also in terms of if I was to count up all the fixed retainer failures that I've seen disproportionately more upper fixed retainers fail than lowers, even though you'd imagine that there have been more lower fixed retainers placed. So it could just go to show that, is there any evidence to say the failure rate of upper fixed retainers is higher than lower fixed retainers? So as far as you know, I don't expect you to be an academic in any way. I know you're very wet-fingered, but as far as you know, because that's a difficult thing to study anyway.
Yeah, it's a difficult thing to study. And in terms of retainer research, I think a lot of the things that we as clinicians do when it comes to retention, because there's not that much research, is mostly based on our clinical experience, what works in our hands and what doesn't. So, and also individual patient preference, right?
Mm-hmm. According to the evidence, which is better?
In terms of fixed versus removable?
Yes, absolutely. Fixed versus removable. Which is the ultimate evidence-based form of retention that you would recommend, or the evidence would recommend? Is there one that's more superior significantly than the other?
Yeah. So, I mean, there are a lot of factors when you're looking at what's more superior and what's not, right? Okay, so firstly, you're looking at how stable do the teeth remain over a period of time with either a fixed retainer or with a removable retainer. So the clinical outcome, essentially. So that's one thing that you're looking at in terms of comparing the two. And the other thing you're looking at is, how is it for the patient? What is the patient preference? What is their experience? What are they more likely to get on with? So if we were actually looking at the research, I'd say probably the best research that we have so far is a randomized controlled trial that's come out of the Royal London by Al Magari and his, all that orthodontic team. They collaborated with a periodontist there, and they compared stability and periodontal health with fixed and with removable retainers over a period of 4 years. And they did that quite recently. So that paper came out in 2018. It's a randomized control trial, and they did everything perfectly. And what they found was that actually over 4 years, the fixed retainer is better clinically in terms of holding your alignment, so the clinical outcome. And in terms of periodontal health, because, a lot of concerns with fixed retainers is that we may be compromising the periodontal health in terms of patients aren't able to clean properly, right? But there was no difference. So the periodontal health was not great, actually, in both groups. So, I think it goes to show that it's important to educate our patients, even in terms of oral hygiene, after they've completed their oral orthodontic treatment. But from that, and from my clinical experience, I would say fixed retainers. If you want to really ensure that you're going to hold the teeth and you're not putting it in the hands of the patient, fixed retainers.
Brilliant. So that's really useful to know. And actually, from the periodontal literature, we know that just because someone has crowding, that it doesn't necessarily mean that their periodontal health will be not as good as someone without crowding. And it's down to the patient who can actually be bothered. So if you're a good brusher, you're a good cleaner routinely, that's going to be true whether you've got crowded teeth or not. So the fact that you said that, hang on, even if they've got a fixed retainer or they don't have a fixed retainer, their periodontal outcomes were similar. It just shows it's actually the patient themselves that needs to take it upon them to do the hard work. So this leads very nicely to a clinical question now is, if you could just, because most people are listening at the moment to this while they're chopping the onions, gardening, washing dishes or whatever, let's talk about one of the most difficult things I found is when you're newly starting to do it is a very fiddly fixed retainer that you're placing. Now, I've tried various methods, including lab made on an acrylic jig, and that is really quick and easy, actually. But for those who have got the wires and those that sometimes you need to bend, and those like the Flex Tech ones that you don't need to bend, can you just run through which you use and talk us through your clinical technique to placing successful fixed retainers on the lower arch?
Okay, so I'm glad you said lower arch, because that's probably, it's the easiest. So you don't have the occlusion to think about, right? So what I what I always use is lab-made stainless steel twist flex multi-strand wire. And what I ask my lab to do is to produce for me a molded wire, so they've bent it by hand, and it's customized with a jig. But it's not an acrylic jig where it's held on both sides with the canines. It's basically a Memosil jig, the soft Memosil. So they basically make the retainer, and then they position it with this Memosil that hangs just over the incisal edges of the centrals. Yeah. So I can then basically take that off the model and then hang it exactly the same way on the lower incisors in my patient. And then it is just sitting there very, very passively. And that's the most important thing for me, is that the retainer is passive. I'm not having to push it or hold it down when I'm bonding it to the teeth. Okay, so now I've got teeth that are prepared. So I clean them. I use a sandblaster after they've been cleaned. Love my Rondaflex. I actually have so many of those. They're my favorite thing. We have them all over the practice. So I clean the teeth, and then we go ahead and we bond it. But I do not hold it down anywhere. So, I'm very, very particular with our lab that it should be made well.
And just to make it really tangible and very so we can visualize it. Once you've got the Memosil on with the fixed retainer in place, essentially, yeah. Oh, fine.
Shall I do next steps? Yeah, because you want to know exactly what do I do then, right? Okay. So now imagine I've got clean teeth. I've tried this retainer on. I've checked that it's fitting nicely. I basically hold it against each tooth and make sure that it's not having to displace to be sitting on that tooth. Okay. Then I remove it. We etch the teeth, bond the teeth. I then hang this retainer back on intraorally, and I start to bond. So I use light flow composite. And I just start with if I start with the most distal tooth. So if it's a canine, usually you'd go lower 3 to 3, right? So I place some bond on that canine and my nurse cures it. That's it, done. Then we do the lateral. Then I remove the Memesil jig, and then I just go around all the teeth, centrals, and then the other side. And that way you're just really ensuring that it is passive, and it's comfortable for the patient, and the teeth aren't going to move.
So you're tacking and you're putting the flowable composite on the canines first, and then removing the.
I don't do this canine and then this canine, because you can then introduce flexion in your fixed retainer. So I go canine, lateral, central, lateral, canine. I go round like that. You're not going to start to then introduce flexion forces. Yeah,
that is a real gem right there. That is a real clinical pearl right there. Mm-hmm. Okay, I'm glad I asked that.
The wire there, then you start to then hold it here. It could lift up in the middle, right? Then you're going to have to push it down onto your central. It's not good.
Well, as you're bonding it on one canine, let's say your lower right canine, and then the lateral, just before you put the composite on the lateral, are you gently pushing the wire up against the teeth with the flat plastic, or not at all?
No, I just, at that point, I would just hold the Memesil jig and just make sure it's not lifting up. As in coming up, but no, don't need to push it. If it's made well, and this is where you've got to really get to know your technician and speak to your technician. And once, sometimes I send them back so they know that she's fussy. I'm not actually, my therapist doesn't put my fixed retainers on for me. I do them myself. I'm that fussy about it. So I think it's just really making sure that your technician knows what you're expecting, and you're expecting a well-adapted passive fit.
Amazing. Thanks so much for that description. Now, here's a little curveball. You've got your fixed retainers, and you've beautifully described how we're going to place it. And I've learned something that actually just be careful not to bond the canine, then the canine. It's a great point you raised there. But what about people who've had expansion? Because we know expansion can relapse, but your fixed retainer is not going to protect from that if it's canine to canine. So what would you do adjunctively for these patients who've had expansion?
Okay, so I'll tell you what I do, right? Because there is actually no fixed or correct way. There's just probably so many ways, but I use dual retention for all my patients. So what I recommend to my patients is let's have a fixed retainer, especially if you've expanded everything and, nothing's going to be stable really. So a fixed retainer, followed by wearing a vacuum formed retainer at nighttime on a part-time basis. So I say, okay, so you've got your fixed retainers, but we need to support the posterior teeth. It's all about sort of explaining to them, why you're doing and why you're asking them to do so much. So the fixed retainer is on, and they then for 4 months wear a nighttime retainer every night. They will then I'll review them, and then based on sort of their experiences, because usually they haven't worn it every night, they may have skipped a night, and they will then explain to you how tight it felt the night after they skipped a night, and you can kind of gauge by questioning them how much stability there is. And then, if I feel comfortable, I'll ask them to reduce the wear to alternate nights for the next 4 months. And then eventually by the end of 12 months, because I review my patients for forever almost. But at the end of 12 months, I would be hoping that we could get them down to 1 or 2 nights a week. But it's really, really customized, Jazz. It's so different for every patient because of so many factors, as you know.
Well, I appreciate you giving us a guideline answer, because that's really helpful. But then you totally raise a great point. Retention should be specific for that individual patient, because certain movements are always going to be less stable. Severe rotations and stuff. You've got to factor that in. So that's covered that really nicely. I appreciate that. When would you ever use? Do you ever use a Hawley retainer, or is that something that's really quite old school and there's no place for it? Sorry if that's a bit controversial. If you describe also for those listeners who don't know what a Hawley retainer is as well, please.
Okay, yeah, good idea. Okay, so a Hawley retainer is a removable retainer that's made of acrylic as the base plate, and then there are stainless steel wires that are molded as cribs to hold it in for retention, so on the 6s, on the 4s or the 5s. And then essentially there's a stainless steel wire, which is called a labial bow, that runs from 3 to 3. And so, that is traditionally what retainers were made of before we came across these vacuum-formed Essex-type retainers. And there is still a place for them, I think. I think if you've got a patient who has a number of teeth missing and, they're going to have time before their prosthodontic work, then, Hawley retainers are quite a nice way to add Pontics to it, to maintain and hold spaces. You can use little wire spurs on either side of the edentulous spaces to really make sure that you don't get closing in of the teeth into that space. So retaining spaces, it's really good. It's also really good for if you need settling, because your teeth, posterior teeth, can still sort of move. I would say those are probably the most times that we would use it, but actually I don't, because patients who have gone to lengths to have treatment that's invisible or unnoticeable or discreet are not going to thank you for giving them a Hawley retainer. And you have to actually really be sure that your patient's going to wear their retainers, right? I mean, you're relying on them. And I just feel that in terms of aesthetics and comfort and speech dysfunction, they're not popular.
I agree, and no one will ever thank you for giving you one of those. So I'm glad you agree with me with my views on Hawley as well. Angela, you've covered my main questions. Now I'm going to take a couple of questions from the Protrusive Dental Community Facebook group. Actually, some really cracking questions have been sent in. Zach, my buddy Zach, who's done some great episodes on comprehensive care, he wants to know about. Well, I'm going to actually read it out because you know what Zach says. He's very wordy. English, yeah. Can you ask about the psychological aspects of retainer wear? So he thinks it's a grossly neglected problem. I never even thought about this before. So I'd rather give my patients 3 sets of removable retainers, okay?
Right.
Design dependent on biomechanics, than a fixed retainer. Because what he's found, what Zach's saying is that for fixed retainer wearers, they think that, oh, that's my retention done. And then 5 years later, if you get an arch form collapse and then they're relapsing all over the show, that's his own words there. What could you say to Zach as an interesting sort of debate or discussion about his viewpoint on the psychological aspects of having a fixed retainer and the patient thinking that's everything, but then you can get an arch form collapse? What would you say to that?
Okay, I think it's all about patient education. Yeah, so the way that I handle retention is from the very first day that patient comes into my surgery. I talk about retention a lot at consultation. Probably half of my chat is about retention, and it's the first part of their treatment plan that I explain to them that, okay, if we move your teeth, this is what we are then going to have to do in terms of maintenance. Are you happy for that to happen? Are you prepared for that to happen? Because if it's a no, that conversation may either need to stop, or you need to then change tact and explain to the patient, well, then your teeth are going to move, because there's no other ways of guaranteeing it. So it's a lot to do with patient education. You've got to consent them for moving their teeth, and knowing that the risks are that their teeth will relapse if they don't play ball with the retention part of the treatment. But we're still, as orthodontists, we're still responsible for their retention. I don't think we can just put the fixed retainer on and expect them to see them in 5 years and think that everything's going to be fine. So yes, that's right. They will still, sometimes you can see a patient with a fixed retainer on, but really warped arch form because, the teeth have been moved in very unstable positions. And then, fixed retainers can also fail along the way. So for me, I think the best way is to give them the fixed retainers, give them the removable retainers, and then ensure that they are coming in for regular maintenance. So in my practice, I have an orthodontic plan that patients join. It's included in their package in the first year. And then following that, they sign up to a plan. And therefore, I then know that they have committed to maintaining their retention, and then I do everything I can to ensure that their teeth then stay straight. So they come in, I check their fixed retainers, I replace them if they need to be replaced, we check their removable retainers, and we keep re-educating them at every point. So the psyche of my patients is not that same psyche that they think their teeth are going to stay straight once they've been straightened. They are absolutely freaked out that their teeth are going to move if they don't carry on with their retainers. So, I think it's a lot to do with how we educate our patients, but that's a lot to do with how we educate ourselves and what we understand about retention. And I think that's probably one of the biggest problems at the moment, that, we're all learning how to move teeth, but there's very little emphasis placed on retention. It's actually the most important part of the plan. If you can't, if those teeth don't stay straight, you're just going to keep getting patients coming back to you. It's just highly frustrating. So yeah, that's probably, the way to do it. Joint responsibility.
Amazing. Education, joint responsibility, and not just relying just on a fixed retainer. There's also that removable component to help with the arch form. Richard McKindo actually on the group also has a different mentality, and that, we have to respect different mentalities. Richard's mentality as a GDP, and a very good one at that. Hello, Richard. I know you're listening, buddy. He provides his patients with, I assume it's Vivera. He said 3 sets of removable retainers. So let's just talk about Viveras, okay? He gives his patients Viveras because he feels safe in knowing that should there be a failure of retention, it's easy to then point the finger at the patient for compliance, right? Because he feels as though if a fixed retainer fails silently, then he feels that the patient will be able to point the finger at the dentist. That's an interesting viewpoint as well. What would you say about that?
So, I don't think one should feel that, that somebody's blaming somebody and somebody's blaming somebody else. There is a solution for this. So if when you give a fixed retainer to a patient, when you place that, if you give them then a removable retainer, that is their secure blanket, okay? And this is how I explain it to the patient, that your fixed retainer can fail. So, when we get to the point where you're only wearing your nighttime retainer one night a week, you're doing that so that you're actually checking your fixed retainer. You're putting it in, and if it feels comfortable, that's fine. Your fixed retainer is doing what it needs to be doing. If it feels tight, you need to pick up the phone and you need to organize to come and see me because there's something wrong. Your teeth are moving and it's probably your fixed retainer is broken. And they get that in writing too. So I would say that is the way to deal with it. Otherwise, you can just put it all on the patient and give them a Vivera retainers. But think about it from your shoes. If when I finish my treatment, I'm not going to want to wear Vivera retainers 24 hours a day for 6 months and then, every night for the rest of my life, because that is actually how they're designed to be retaining the teeth. I don't think my patients would thank me for making them wear their aligners like that. It's not what I would want for myself.
I appreciate that. And also, I think the answer to, or not an answer, but just a good, valid point to this question and the last one is a belts and braces approach, right? You want your fixed retention and your removal, and they do their tasks together and it gets amplified, and the whole patient education. So that's all, wrapped within that as a package. So last question out from Rob.
Just one more point about fixed retainers. When it comes to sort of, orthodontists and GDPs, it kind of feels like sometimes fixed retainers are the bane of our lives, right? Like, so patients are coming in, it's broken again, and, then you're having to fix it. But I tell you what, if you put them on this, if you have some sort of a plan where you know that you are being remunerated for fixing their retainers, and they know that they're not paying every time for an emergency appointment, the psyche of the psychological feeling about fixed retainers, it really changes, and it just becomes about, okay, we're all in this together and we're going to look after it together. And you get the odd patient who has come in a number of times, but then you also have the odd patients who can maintain a fixed retainer for 3 years and nothing happens, So I think the psyche about fixed retainers has to change, and it's actually about the amount of time that we have to spend in our diaries looking after them, and how we're remunerated. So I think everyone should really think about a plan. It really changes everything.
When you said it about 7-8 minutes ago, you mentioned the orthodontic plan. I was like, oh my God, this is amazing. And then I got sidetracked. But you're right, this plan, so that there's joint responsibility and the patient doesn't feel like they're paying suddenly like a higher fee when they're coming in when it's broken, and they sort of feel protected. It's like an insurance policy for them. And it also means that you as a dentist, orthodontist, are remunerated as well along the way. So then it doesn't feel like, sometimes you come in and maybe it's been, 7 months since you placed a fixed retainer, and then you feel like, okay, I can't possibly charge this patient because it's been so soon. But I think there's something in it for both the dentist and the patient to have an orthodontic plan. So that is a real gem. So if you guys out there are doing a fair amount of orthodontics, as Angela says, consider having a plan component, because that will really get rid of those issues, I guess.
Yeah. And making sure that your patients know nothing's for life, they don't go and have their hair colored and think they're going to do it once and then that's it. It's done, They need to understand there's maintenance involved. It's an aesthetic treatment, always going to need maintenance.
It's the same with composite polishing. It's the same with teeth whitening. So, it's the same with that. Yeah. So I appreciate that. Last question now is sent from Rob Arden. Hi, Rob. Thanks for listening, buddy. Does anyone have a good rule of thumb for upper anterior bonded retainer? See, Angela, we couldn't go the whole episode without discussing this very annoying thing about upper fixed retainers. He says, especially when occlusion means space is limited. So he knows that Tiff on IAS courses, and Tiff's been a great guest on the podcast before, and we've sort of discussed this a similar topic about using restorative composites, so like your nano hybrid or something like that, instead of flowable, and dialing the patients in. So dialing as in Dahl, the chap who came up with the concept of bonding things in high at the front and letting the posterior settle, intrusion at the front. So please do refer back to episodes 16 and 17, I think it was, if you guys want to listen to more about a Dahl. But essentially, it's sometimes difficult because you want to make the patient as comfortable as possible. So you want to actually shave that composite down so it's not too proud. But at the same time, you want to have the strength. But I've been thinking, in my diploma, we never discussed this technique. And I've got a feeling that orthodontists don't routinely dial upper anterior retainers. And my thinking is because, and that's actually Goss as well to thank, because when he came on as a guest, is because part of the objectives of comprehensive orthodontics is to get the overbite correct enough so that you actually have your space, right?
Yeah, that's you've just hit the nail on the head. It's a great question, Rob, because it is like something that bothers every clinician at some point, in their working time. But as orthodontists, when we're training, we never get really taught about short-term orthodontics or every patient is treated comprehensively, which means that we are finishing them to the ideal overbite and the ideal overjet. So essentially, you should always have enough space to put on the fixed retainer without it affecting the occlusion. Okay, but in real life, now we know that, there are patients who are only going to request anterior alignment only, maybe only upper arch treatment. And firstly, I think the most important thing is to know from the outset how you're going to be finishing the occlusion, and to let the patient know. Don't promise them a fixed retainer when then afterwards you can't put one on. That's really important.
Absolutely.
But if you are hell-bent on putting on that fixed retainer, or the patient is really convinced that that's the only way they want to retain their teeth, and you don't have the space occlusally to do it, then I don't see a problem with carrying out the doll technique. I work very, very closely with prosthodontists, and so I see a lot of restorative stuff going on in the practice, and I see, the doll concept. It works amazingly. So I have no problems. Sometimes for my patients, when I've had problems with the occlusion, the prosthodontist has just put on canine ramps with composite. So palatally building up the palatal surfaces of the upper canines. So then that opens up the bite a little, allows me space to put on the fixed retainers. And then there's a little bit of that darling going on. And again, it's just making sure that your patients understand that they're going to have a little bit of tiny open bite at the back, and that it's going to take months for that to resolve.
That's fantastic, and I think you raised two good points there. Many good points. So the two I want to highlight is patient communication. Sometimes from the outset, as a GDP, we do compromise treatment. Just look on Instagram, right? And you know that you're not going to be able to fully correct this overbite without committing to a comprehensive route of treatment, which, I think we should all open our eyes to. It's really good to do that. But if and the patient knows that you're compromising and they've had a specialist consultation and they know what they're getting themselves into, then from the outset that you probably won't have enough space. So then communication and recognizing that. And then B, you actually mentioned a really good tip about adding composite on the canines there. But if anyone's going to do it, make sure you design it in a way that the load is transmitted into the canines along the long axis, which would actually help. And again, patient communication so that they understand what it's going to feel like in terms of at the front and how long it's going to settle. There are review protocol that would be sort of arranged with that, and a bit of contingency planning. What happens if it doesn't happen? Now, we know it's quite predictable, but you have the odd patient where it might not happen. So just have all that upfront in a really good conversation with the patient is key. Angela, you've been absolutely fantastic. I knew this would be brilliant, and it has been about retention. I think we've really covered. I'm sorry, I threw some curveballs at you.
There's so much to talk about with retainers, right?
We could easily go on. We can easily go on, right? Because we can talk more about technique at the top. We can talk about when I've seen some case before where the twist flexes, started to torque the teeth some years from now and stuff like that. But we're running out of time. But I just want to say thank you so much for coming on to sharing, all these gems. If there are some people who want to learn more from you, where can they find out more about your, I know you've done quite a few lectures on tubules and whatnot. Do you offer any educational programs, any study clubs for dentists?
So we have the Dental Rooms Academy, and that's part of our practice. And we regularly carry out lectures there. We have an in-house training facility, and so we quite often once a month. Pre-COVID times, once a month we were doing case discussions with every time there's two specialists, so quite often I'm there. But that's my favorite place. My other favorite place is tubules. I love speaking on that. We've just started an aligner panel there. We're going to be called the A-Team, and we'll be talking a lot about and gauze and a few other great clinicians. So those are probably the main channels for me. So through the Dental Rooms Academy and through tubules.
And your Instagram handle. Yep. Please tell us your Instagram handle.
Dr. Angela Auluck. So please message me. I love that platform. It's my favorite thing at the moment.
And one of the reasons I also wanted to get you on is because you, like me, are a big cricket fan.
Yes. I love cricket. So do my children.
I remember. So I know you're a Kings 11 Punjab fan in the IPL, but your children and I think your family are Mumbai Indian fans.
They are indeed. So they took it this time, but that sort of helped keep the peace. But Jazz, we're getting there. That Kings 11. I feel like next time's going to be our time.
I feel like Liverpool felt for like 30 years, like next year's our season, So, but I'm hoping it will come true, and next year it will be our season in the IPL. So, Angela, thank you so much once again. Really appreciate you coming on the show.
Thank you so much, Jazz.
I hope you enjoyed that with Angela. Thank you so much for listening all the way to the end. If you're not already part of it, do join the Protrusive Dental Community Facebook group, where we've got such a thriving community. It hasn't got like thousands of dentists. It's got a small group, but it's all the Protruserati who enjoy the podcast. And I just feel the love and the connection and the chemistry between everyone. I think we're also helpful in this group because I think it's like our safe little place, because we're kind of like-minded. Like if you listen to this, you are similar to someone else who listens to Protrusive Dental Podcast. So if you want to find that community, do join the Protrusive Dental Community Facebook group. I look forward to seeing you there. Anyway, I'll catch you in the next episode, which is all about elastics in Invisalign, the do's and don'ts of elastics. And I'll catch you same time, same place next week. See ya.